Good afternoon, everybody. Thanks for joining us today in our cardiovascular groundhouse. Welcome, Dr. Bhave, and thank you for joining us today. My name is Lorena Tejes. I work at La Cardio, and it's my pleasure to introduce to you our moderators for this event. Dr. Carlos Ortiz, clinical cardiologist, and Dr. Hector Medina, Chief of Cardiovascular Imaging at La Cardio. Welcome, and thank you for moderating this event.
Muy buenas tardes a todos. Muchas gracias por acompañarnos en este gran round interesante en cardiología. Mi nombre es Carlos Ortiz y me complace estarlos acompañando como moderador de esta conferencia. Les recordamos que al conectarse a esta conferencia autorizan el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la Ley 1581 del 2012 y nuestra publicidad de datos personales, la cual pueden consultar en www.cardioinfantil.org. De igual forma, le informamos que esta conferencia está siendo grabada en este momento. El chat de preguntas se encuentra habilitado en la barra de participantes. Le agradecemos dejar allí sus inquietudes, las cuales resolveremos al final de la sesión. Hoy tenemos el gran honor de contar con la participación como expositora de la doctora Nicole Bhave en la conferencia Challenge in Cardionephrology, Heart Failure and Valve Disease. El entrenamiento de la doctora Bhave incluye Medical School at Harvard Medical School, Resident in Internal Medicine at Massachusetts General Hospital, Fellowship in Cardiology and Advanced Cardiac Imaging at University of Chicago. Dr. Bhave is a cardiologist and echocardiographer with an interest in cardiovascular care of patients with kidney disease. She currently serves as director at the Arbor Veteran Affairs Echocardiography Laboratory at the University of Michigan. She is active in several professional societies, including in American College of Cardiology and the American Society of Echocardiography. Dr. Bhave has authored and co-authored more than 60 publications, present over 40 abstracts, and has lectured at major national and international meetings. Welcome, Dr. Bhave, and you may get started. Welcome again.
Gracias, Dr. Ortiz. Thank you so much for having me here this afternoon. So as Dr. Ortiz mentioned, I'm at the University of Michigan. My background is in general cardiology and echocardiography, but my particular niche here is in this cardiorenal medicine space. And this really grew out of a need at our center. We do many kidney transplants here, about 200 per year. And these patients obviously are quite complicated from a cardiovascular point of view. And so my colleagues in nephrology and surgery engaged me in taking care of them. And over the past several years, I've learned so much and really grown to have a true passion for taking care of this population. So I'm happy to share with you some insights today. Let me share my screen. So I have no relevant disclosures for today's presentation. So the objectives for my talk this afternoon. First, I'd like to describe how I foster a collaborative approach to care of patients with kidney disease and heart disease. Second, talk a bit about how to optimize pharmacotherapy for heart disease in the setting of kidney failure. And then also highlight management strategies for valvular disease in this population. So this is a case of a gentleman I saw a few years ago. He was 70 years old, had diabetes, hypertension, and end-stage renal disease, had been on hemodialysis for 3 years, and was interested in a living donor kidney transplant. He felt generally poorly on dialysis and was quite sedentary. He endorsed fatigue, but no dyspnea on exertion or angina, albeit at a low level of exertion. And he was referred for a dobutamine stress echo, and I happened to be in the echo lab that day. So here was his presenting EKG. And you can see that there's no organized atrial activity. He's in atrial fibrillation. There's also left axis deviation and a nonspecific intraventricular conduction delay. However, his heart rate is controlled. So the sonographer came and showed me the EKG, and I went to speak with him. And I noticed right away that he was volume overloaded. He had jugular venous distension, he had rales in his lungs, and he also had pitting edema all the way to his lower thighs. On further history, it turned out that he had been intentionally losing weight as advised by the transplant team so that he could get through the surgery as safely as possible. But they had not adjusted his dry weight at hemodialysis. And so his weight was the same, but he was volume overloaded. And according to his family, he appeared dyspneic just after walking from the parking lot to the office. So this patient is, this is a very common story. These are data from the US Renal Data System, which is data on all the dialysis patients in the United States, essentially. And every type of cardiovascular disease is more prevalent in the dialysis population than in the population at large. In general, any type of cardiovascular disease is about twice as common. And problems that are particularly prevalent are coronary artery disease, heart failure, and atrial fibrillation, unfortunately. Looking at mortality in the dialysis population, a little over half of death in this population is related to cardiovascular causes. You can see that there's a big bucket of 40% here that's arrhythmia/cardiac arrest, and in many of these cases we don't know the exact trigger. Heart failure is only labeled in 3% of the cases, but my suspicion is that many of these so-called arrhythmic arrests are actually PEA arrests due to heart failure. So I think it's an even bigger problem than clinicians recognize. Excuse me just one second. So cardiovascular disease and end-stage renal disease has many faces. Left ventricular dysfunction, both systolic and diastolic, is extremely common. We see a lot of pulmonary hypertension and right ventricular dysfunction. Coronary artery disease, of course, arrhythmia, most commonly atrial fibrillation, and then valvular disease. But at the end of the day, most of these patients have some degree of heart failure. For some of them, it's what we would call stage A, which is subclinical. They may have some underlying structural heart disease, such as LVH, for instance, that puts them at risk of developing heart failure. But many of these people have elevated intracardiac filling pressures with or without left ventricular systolic dysfunction. And the pathophysiology here is quite complex, involving a number of systems. At the end of the day, reduced perfusion related to reduced cardiac output can reduce the kidney function, and also venous congestion can lead to decreased kidney function. And so heart failure begets kidney failure and vice versa. There's also a complex interplay with the peripheral vasculature, the adrenal gland, and the sympathetic nervous system. So to get back to our case, this patient, I spoke with a transplant nephrologist who then called his dialysis nephrologist, and his ultrafiltration was intensified. He had a couple of extra sessions, they extended the length of the runs, and clinically he improved quite significantly. His atrial fibrillation was already rate controlled with the beta blocker. In order to risk stratify him from an ischemia standpoint, we chose a vasodilator nuclear study, which showed a normal left ventricular ejection fraction, and he had some fixed defects consistent with prior myocardial infarction, but no evidence of ischemia. And after he was optimized medically, he underwent a successful transplant. And I saw him once after that, and he was doing so well, I actually haven't needed to see him again because his heart failure improved significantly with a functioning kidney. So this was a real success story. So this is a chart from the 2019 American Heart Association scientific statement on cardiorenal syndromes. And oftentimes in the cardiology world, when we say cardiorenal syndrome, we're referring to type 2 cardiorenal syndrome, which is a patient who has chronic heart failure leading to kidney congestion and reduced perfusion that results in chronic kidney disease. But many of the patients that I see, and those of you who take care of dialysis patients, are also very familiar with this phenotype, the type 4, which is a chronic renal cardiac syndrome where chronic kidney disease results in chronic heart failure. When you're seeing a patient who is on dialysis and you're asking them about their heart failure symptoms, I think this is a really helpful framework for thinking about their symptomatology. This was from the Acute Dialysis Quality Initiative, published in 2015. So on any given day, if you ask a dialysis patient how they're feeling, how their breathing is, you might get an answer that's very different than on another day because it all depends on where they are in their dialysis cycle. So the healthiest patients would be class 1. They may have some echo findings like left ventricular hypertrophy or aortic sclerosis, but they've never had clinical heart disease, never been admitted to the hospital, they're never dyspneic, they never have orthopnea. But many of our patients live in this class 2 and 3 world where they may be short of breath the night before dialysis, they finish their dialysis run, they feel okay, and then 2 days later, they're short of breath again. And then there are some patients who, no matter how much they're ultrafiltered, will always be dyspneic. And so it's really important to keep this classification in mind when you're interviewing patients to understand how they feel throughout their week. This is a small study that was done with an implanted monitor in the pulmonary artery, kind of like a CardioMEMS device, looking at filling pressures over the course of a week. So this is a patient who undergoes thrice weekly hemodialysis on Monday, Wednesday, and Friday. And you can see that their filling pressures, the right ventricular systolic pressure and the pulmonary diastolic pressure, are lowered at dialysis, and then they rise, and then they fall, and then they rise and they fall. And generally, because most people, at least in the United States, only dialyze 3 times weekly, there's a 2-day period during which they don't dialyze. And for this person, that was Saturday and Sunday. And lo and behold, by Monday morning, their pressures are the highest they are during the entire week. And if you talk to patients about this, sometimes you'll be able to elicit a history like, oh yeah, Sunday nights are kind of the worst for me. That's when I feel the most short of breath. That's when I end up going to the emergency room. So knowing all this, we need to think about how this impacts outcomes, not just symptomatology, but also outcomes. This was a very large study of over 32,000 patients looking at mortality over the course of a dialysis week, essentially. And you can see that causes like infectious and vascular causes really did not vary according to what day of the week it was. But all-cause mortality was certainly higher after that longer intradialytic interval. So for Monday, Wednesday, Friday dialysis patients, this would be like Monday morning. For Tuesday, Wednesday, Thursday patients, it would be Tuesday morning. And this is mostly driven by cardiac causes. So to dial down into that a little bit, stroke was not particularly more common. Myocardial infarction was not particularly more common at the beginning of the week. Dysrhythmia was a bit more common, and particularly heart failure was more common. So knowing all of that, does more frequent hemodialysis actually improve outcomes? This was the Frequent Hemodialysis Network daily trial. This was published back in 2016. They looked at 245 patients and looked at conventional hemodialysis, which would be 3 times a week, and frequent hemodialysis, which would be 5 times per week. And you can see that over a period of several years, patients who underwent frequent hemodialysis had reduced mortality. Again, reflecting the fact that heart failure and volume overload is probably driving a lot of the adverse outcomes that we see in patients who only have dialysis 3 times per week. So unfortunately, in the United States, we are not doing as well as we could be in terms of initiating home dialytic therapies. We're doing better than we were several years ago, still lag behind much of the rest of the world. And I know in Colombia, you do a lot more peritoneal dialysis than we do. So if you look, this is 2016 data. So this is home hemodialysis, which is quite rare. It's still less than 1% of our patients. Peritoneal dialysis at that time was about 10%. and now, as of 2019, is about 12% of patients. But the vast majority of American dialysis patients are still on in-center 3 times a week dialysis. So what are some of the barriers to initiating home dialysis? So I think probably the biggest 3 are lack of social support. So especially for home hemodialysis, a partner is usually needed to help set up equipment and for safety reasons. Many patients have told me, I don't really want to touch the needles or the catheters. I want somebody else to deal with that. I just feel safer if it's in somebody else's hands. And then, of course, limited health literacy. Unfortunately, some of the problems like untreated diabetes and hypertension that get people onto dialysis in the first place also stem from limited health literacy and limited access to care, which is a real problem. And then, unfortunately, there are logistical and financial restrictions on this. So in the United States, many dialysis centers either do not support peritoneal dialysis or have very few peritoneal dialysis patients. So clinicians and nurses just have less experience with the modality. And then Medicare places financial restrictions on hemodialysis treatments. So on average, as of 2019, only about 3.8 sessions per week were covered for home hemodialysis, whereas in an ideal world, many patients would prefer to dialyze 5 or 6 times a week to keep their volume status and their blood pressures optimized. So these are some of the challenges that we face in the real world with initiating home dialytic therapies. To get an understanding of how patients are faring on dialysis and how their volume status is, so forth, one question people will sometimes open with is, well, how's dialysis going? And if it's going great, then there's probably not much to tell you. And if it's going terribly, then they'll remember all those details about what happened on that day when their blood pressure crashed and they felt terrible. But in reality, in order to get the most accurate information, what I usually do is I have my nurses call the dialysis center and get the run sheets so I can actually see minute to minute what's happening with the blood pressure and so forth. Some patients really know their dry weight, they really know their blood pressures, but many patients just don't pay enough attention for what they tell us to be helpful in terms of understanding how to optimize their therapy. So these are some of the key data that I look at when I look at a dialysis flow sheet. You want to know what the pre-dialysis blood pressures are, the post-dialysis blood pressure, and then the minimum. Heart rates, of course. How much volume is taken off at each session, and then weights, their target weight and their intradialytic weight gain. One of the really common problems that we face is intradialytic hypotension. So a patient may come in normotensive or even hypertensive rather, and then as they're on the machine, their blood pressure may drop, and that can often limit how much fluid can be taken off, and it can also often limit the medical therapies we're able to give them for hypertension and heart failure. And depending on the patient's body size, oftentimes the more fluid that's taken off during a run, the higher the risk of that intradialytic hypotension. So if you get to more than, say, 3.5 liters of ultrafiltration, the risk of hypotension during a run is much, much higher. So what are some practical solutions for managing dialysis issues in patients who have clinical heart failure? If they're having heart failure symptoms between sessions, then at a patient level, encourage them to decrease their sodium and fluid intake. So it may be difficult for many patients, but if they can limit their water and their fluid intake to about 1 liter a day, that's usually very, very helpful. Asking the dialysis team to lower the dry weight or do some extra sessions to get more fluid off can be very helpful. If the patient's still making urine, as many peritoneal dialysis patients do, consider some loop diuretics potentially on the non-dialysis days. And then, of course, more frequent dialysis if that's an option, potentially switching to peritoneal dialysis or home hemodialysis if that's feasible for the patient. Hypertension is extremely common in this population. So the first strategy, because venous hypertension is so common, is to try to get fluid off. And then in terms of pharmacotherapy, there are many options. some of which are better than others in heart failure patients, and I'll get to that in a couple of minutes. If the patient's having intradialytic hypotension, again, trying to decrease the sodium and fluid intake so that less fluid has to be taken off at each session is really helpful. It's also possible sometimes to extend the dialysis run. So instead of running for 2.5 hours, the same amount of fluid is taken off in 4 hours so that the ultrafiltration rate is slower. Lowering the dialysate temperature is something that may be an option. It can be uncomfortable for patients, but it is something that nephrologists will sometimes do. And then, of course, frequent dialysis or switching to peritoneal dialysis so that we don't have these large rapid fluid shifts. So just a little food for thought. Which of the following is the most valuable in determining a patient's volume status? Is it physical exam, history and symptoms, lab values, or imaging such as echo and chest x-ray? Well, it's really all of the above. It's so difficult. One single data point can never really tell you a patient's volume status. So this is one of the reasons why I think communication is incredibly valuable in trying to optimize a patient with heart failure when they're on dialysis. So the person who may know the most about the situation is the patient. Oftentimes, if they've had heart failure before and they're feeling well now, they can remember those symptoms of orthopnea and dyspnea, and they can tell you how they feel relative to how they felt just before they started dialysis, for instance. The dialysis staff will generally be able to tell you how things are going, if they've been able to make progress getting the dry weight down, and whether the patient is actually adhering to their medical regimen and coming to all their appointments. The dialysis nephrologist in this country usually sees the patient about once a month, and the more complicated patients they often know very well. So I have some very valuable conversations with nephrologists, particularly if I think I have information that can help them optimize the patient. Cardiologists, depending on what your setup is, I often see people as a consultant, meaning that they have a local cardiologist and I'm seeing them prior to kidney transplant. With that said, I may actually have more information than the local cardiologist if I'm engaging with the dialysis team, but I always try to loop in the local cardiologist to let them know what information I'm getting. If the patient's been admitted to the hospital, then it's certainly important to understand what's transpired there, particularly if they've had some weight loss from poor nutrition or deconditioning, then their dry weight needs to be adjusted. The kidney transplant team will kind of synthesize all of this information, of course, and then the primary care physician may be more or less involved than the local nephrologist, depending on the patient's overall clinical picture. So in terms of managing left heart disease and end-stage renal disease, I really think of this as a spectrum between systolic and diastolic heart failure. This is actually the same patient, just a couple of months apart, and what happened in between here was that the patient's kidney function worsened. They became fluid overloaded and hypertensive, and their heart worsened. And then when they went on dialysis and things improved, their ejection fraction also improved. And I sort of joke that the ejection fraction is like a roller coaster. I mean, it could differ it could change in just a very short period of time, depending on the loading conditions. So what are some of the pharmacotherapies that we can use in this population? Certainly beta blockers are a mainstay of therapy for heart failure with reduced ejection fraction. But unfortunately, the data in this population is somewhat limited. And that's in part because historically, many heart failure trials, not only did they not include renal endpoints, but they actually excluded patients who had serious kidney dysfunction. So for instance, in Copernicus, any clinically important renal disease was excluded. And in Merit HF, the metoprolol succinate trial, any major disease other than cardiac disease led to patient exclusion. COMET, the trial that looked at carvedilol versus metoprolol tartrate, didn't specifically exclude patients with kidney disease, but it did exclude patients with severe hypertension. So that would automatically take many dialysis patients out of the picture. So there's actually only been one randomized controlled trial on beta blockade in the setting of heart failure with reduced ejection fraction in dialysis patients. It only had 114 patients, and to qualify, patients had to have an ejection fraction of less than 35%. And they were followed for about 2 years. But the survival benefit was marked. So even in patients who were taking carvedilol, only about half survived, but that was twice more than the number, almost twice more than the number that were taking placebo. So this is really good evidence that we should definitely be giving beta blockers to these patients whenever possible, just as we should in the general HFrEF population. But which beta blocker is the best? So two of the most commonly used beta blockers in the US are metoprolol and carvedilol, both because they have a strong evidence base in heart failure and they're widely available and generic. So this was a study, an observational study that looked at metoprolol versus carvedilol in dialysis patients. It's important to keep in mind that metoprolol is a dialyzable beta blocker, whereas carvedilol is non-dialyzable. So not all of these patients had heart failure, about 35% did. But you can see that there was a trend toward an improvement in all-cause mortality and cardiovascular mortality with carvedilol. And here's another study. Sorry, let me go back for a second. Oh, I'm sorry, I misspoke. So this actually showed a slight worsening of mortality with carvedilol versus metoprolol. In this is actually looking at what's happening with blood pressures in these patients. So patients who have intradialytic hypotension on carvedilol actually do worse than patients who do not have intradialytic hypotension. So sort of the take home here is that if low blood pressures are an issue, you should not be using carvedilol, or you should actually be using smaller doses of carvedilol. I actually tend to prefer carvedilol in these patients because it achieves sort of a steady state in the system and is not removed by dialysis. With that said, if they have problems with intradialytic hypotension, I tend to use a very low dose, like 3.125 milligrams twice a day. Or if I use metoprolol succinate, I have them take it after their dialysis run so that it's in the system as much as possible. And it's important to explain to patients that it's not just about what the medicine's doing to your blood pressure, it's about how much of that medicine that your heart is seeing in order to strengthen it. That's how I explain it to patients. So what about other classes of drugs? So mineralocorticoid receptor antagonists in end-stage renal disease are, I would say, a little bit controversial. From a physiologic standpoint, suppressing aldosterone production in these patients makes a lot of sense. And I say that because there's a failure of aldosterone suppression in the setting of chronic kidney disease. So with higher sodium intake and higher blood pressures, aldosterone production should be suppressed. But in chronic kidney disease, that suppression is impaired, and it's even more impaired in end-stage renal disease. And aldosterone has pro-fibrotic effects and also promotes left ventricular hypertrophy. And this is probably a big part of the reason why so many of these patients have such significant left ventricular hypertrophy, leading to diastolic dysfunction and in the long run, systolic dysfunction. So from a practical standpoint, can we use spironolactone in end-stage renal disease? And this is definitely something that's just outside of my comfort zone. And the main reason for that is hyperkalemia. So many patients, if you go back through their history, you talk to them, you talk to their dialysis providers, at some point in time they will have hyperkalemia. And I definitely tend to shy away from using this drug if there's been any recent hyperkalemia. With that said, there are a couple of small studies that have suggested that there could be some benefit of this drug in this population, and there are ongoing randomized controlled trials that are looking at it. my one piece of advice would be that if you're going to start this medication, just as you would with an ACE inhibitor or an angiotensin receptor blocker, it's important to communicate with the dialysis team to let them know that they need to be following the serum potassium level more closely than they otherwise would. But something to really keep in mind, particularly if you have a patient with a stable potassium level. So to summarize a few important points about managing heart failure with reduced ejection fraction in dialysis, it's important to collaborate with the nephrology and dialysis team and the patient to really optimize their volume status, maximize their guideline-directed medical therapy as their blood pressure allows, and in the long run, consider referring them for a kidney transplant, because if the transplant is successful, their LV function will likely improve. So shifting gears just a bit to pulmonary hypertension. This is very common. Its prevalence based on echocardiographic studies is about 50% in the dialysis population. And most of these echo studies have focused on right ventricular systolic pressure. As we know, postcapillary and multifactorial pulmonary hypertension are very common in this population. So the most common would be group 2 or venous pulmonary hypertension, and then group 5, which is sort of a grab bag of group 2, maybe some group 3 related to sleep apnea and other lung diseases, and then also the end-stage renal disease itself. Tricuspid regurgitation in these patients is most often functional, meaning that there's nothing inherently wrong with the valve leaflets. It's just that the pressure is high on the right side of the heart and the annulus may be dilated as a result of that high pressure. So this is a patient of mine who has moderate functional tricuspid regurgitation, as you can see here on the left. And on this echo, her IVC was dilated and non-collapsible. So her RVSP was 48 plus 15, so 63. So clearly her right-sided filling pressures were elevated. The context here is that her systolic blood pressure at the time was about 180, and she was clearly fluid overloaded on exam. So I knew that this is something that would improve with getting fluid off. In terms of thinking about the big picture with these patients, so if many of them have pulmonary venous hypertension, you know, what are really the markers of, or what are the harbingers of worsened outcomes in these patients? And really, it's mostly about the right ventricle, as it is in all comers with pulmonary hypertension. So this is a patient of mine who I saw before a kidney transplant. And you can see here that the right side of his heart is not contracting well. And there's intraventricular septal flattening in systole and diastole, consistent with right ventricular pressure and volume overload. He also has a pericardial effusion, which may have been partly uremic, related to underdialysis. And if you look closely at his mitral valve here, you can see that there's an abnormality, so there's some thickening, and he actually has a flail mitral leaflet that you can't fully appreciate on here. But he essentially had pulmonary venous hypertension that led in the long term to profound right heart failure as well. And my suspicion was that this was from subclinical mitral endocarditis. So this was a Mayo Clinic study looking at over 600 patients with end-stage renal disease. And these were all patients who had either just begun dialysis or were just about to start dialysis. And they risk stratified them based on their LV and RV function. And you can see that here in blue, the patients with relatively preserved LV function and normal RV function did the best. And those with low LVEF and an abnormal RV did the worst. At our own center, we did a small study looking at patients, retrospectively looking at patients who had gone to kidney transplant. So it was 80 patients, and I looked at echoes that had been done within a year prior to transplant. About 10% of these patients had RV dysfunction, and all of the patients who had RV dysfunction met our primary composite endpoint of delayed graft function, graft failure, or death as compared to only 60% of the others. So this was clearly a marker of poor prognosis. Notably, the RVSP was not measurable on over half of these echoes, just drawing attention to the fact that if we're screening for pulmonary hypertension using transthoracic echo before a kidney transplant, it's really important not just to focus on the right ventricular systolic pressure, but also all the right ventricular parameters, size and function. So to summarize how I approach pulmonary hypertension and end-stage kidney disease, first, make sure that their volume optimized as best you can. Treat their LV failure using medications. If they're not on dialysis yet, go ahead and let them initiate dialysis and then repeat an echo. And if the right ventricle looks better at that point, then you probably don't need to do a pulmonary hypertension focused workup. But if they have not improved, that may be the time to consider a right heart catheterization to establish their pulmonary artery pressures and their pulmonary vascular resistance, and consider referral to a pulmonary hypertension specialist to see if they'd be eligible for any pH-specific therapies. So valve disease and chronic kidney disease and end-stage renal disease, the most commonly falls into one of three categories. Calcific, here on the left, you can see this is a patient of mine with very extensive mitral annular and leaflet calcification. Functional, as in the case of tricuspid regurgitation, particularly in the setting of pulmonary hypertension, and then infective. And here on this TE, you can see there's a large mitral vegetation. So calcific valve disease most commonly involves the aortic valve, as seen here on the right, with significant aortic stenosis, and the mitral valve, as seen here on the left. It's really important to remember that depending on the patient's calcium phosphate metabolism, they can have rapidly progressive valve disease, particularly aortic stenosis. And so I often image these patients more often than I would patients without chronic kidney disease. So if they have mild aortic stenosis, rather than wait 3 to 5 years to re-echo them, I might do it in 2 years. And if they have moderate aortic stenosis, I'd probably do it once a year, just to make sure that that aortic valve isn't worsening rapidly. So the pathophysiology of aortic stenosis in chronic kidney disease essentially involves inflammation, fibroblast activation, and then activation of these osteoblast-like cells that lead to fibrosis and calcification. And unfortunately, once this process has really gotten started, it's very, very difficult, if not impossible, to reverse. This is a patient of mine who actually had previously had a kidney transplant when she was younger, but came to see me when she was in her early 90s. She was presenting with worsening kidney function as well as exertional dyspnea. And on her echo, her ejection fraction had dropped from 60% on a prior to now 40%. And this is a short axis view of her aortic valve. So you can see it's severely sclerosed and the cusp excursion is severely reduced. The valve area was 0.7 centimeters squared and the mean gradient was 26. And all of her findings were consistent with low flow, low gradient, severe aortic stenosis. So I referred her for a TAVI. She was, for many reasons, high risk for any sort of surgical intervention. She underwent deployment of a self-expanding TAVI, which you can see here, and did very well. She was discharged on post-op day 2. She had only mild paravalvular regurgitation, and her creatinine, as we often see in these patients, actually improved after the TAVI, probably reflective of improved forward flow to the graft. So there is a few pitfalls that are important to remember when you're quantifying aortic stenosis in patients with kidney disease. Probably one of the biggest issues is measurement of the left ventricular outflow tract for the continuity equation can be difficult because of calcification. So it's very easy to undermeasure the LVOT and thereby underestimate the valve area. Patients with AV fistulas for dialysis can have a high flow state, and therefore the gradients can overestimate the aortic stenosis severity. Conversely, particularly in patients like the lady I just described, if they have left ventricular hypertrophy and a small cavity, they can have a low flow state, and then the gradients can underestimate aortic stenosis severity. Although CT calcium scoring can be a helpful ancillary tool for quantifying AS, cutoffs are not really established in this population, so it's hard to extrapolate from cutoffs for the general population. So deciding between TAVI and surgical valve intervention in CKD and end-stage renal disease hinges on several factors. If you have a patient who is less than 55 years old and they don't have a high bleeding risk, then as in the general population, a mechanical AVR may be their best bet if they're a reasonable surgical candidate. If a patient has anatomy that's unfavorable for a TAVR, like a lot of left ventricular outflow tract calcification or severe peripheral arterial disease that would preclude transfemoral access, then a bioprosthetic AVR may be a better choice than a TAVI. And also if they have multivessel or left main coronary artery disease, a TAVI may be a worse choice because it's more difficult to access the vessels later on for cath. But most of our patients with advanced kidney disease will be in the intermediate to high surgical risk category. And so I would say more commonly, I end up referring these patients for TAVI than for surgical AVR, particularly if their anatomy is conducive to a future valve-in-valve procedure. And generally at our institution, if a bioprosthetic valve or a TAVI is 21 millimeter diameter or smaller, then a valve-in-valve procedure is not felt to be feasible. But if it's larger than that, then perhaps a few years down the line, if the valve degenerates, they could have a valve-in-valve TAVI. So I want to take a couple minutes to talk about mitral regurgitation. And as with tricuspid regurgitation, this is a very load-dependent lesion. This is a patient of mine who's in her 40s. You can see that she has mitral annular calcification and some leaflet restriction. And the degree of her MR has varied quite a bit over the years. This was an echo that she had at our institution with me last year when she was volume optimized. You can see that her inferior vena cava was small and collapsible, and she was feeling quite well. And then she came to see me recently, and her MR was much worse, unfortunately. And I later learned that her blood pressure had been systolics, 180s, 200s at dialysis, and her inferior vena cava was dilated and not collapsible. So what we're doing is lowering her dry weight, and then I'm going to do whatever I need to do to optimize her blood pressure after her dry weight is lowered with medications. At one point in the past, she was actually told that she needed mitral valve surgery, but I'm hopeful that if we optimize her medically, that we will be able to make her MR look like it did a year ago. Endocarditis is a great scourge on this population, and I'm sure you see some of this in your center. This is a patient of mine who had a kidney transplant in early 2021, and then called our office to complain of some lower extremity edema and fatigue. I encouraged her to come see me. She didn't have transportation. This kind of went on for a couple of weeks. And finally, she went to the emergency room, and we did a bedside echo that showed severe AR. So I did this TE on her, and you can see that unfortunately her aortic valve is just destroyed. So this was subacute endocarditis with lactobacillus, which she was probably at higher risk for because of her immunosuppression. Fortunately, she went on to surgical AVR and actually did quite well in spite of all her risk factors. But I think what happened is that she required some hemodialysis in the post-transplant period because of delayed graft function, and that was probably her major risk factor. So to summarize valve disease in this challenging patient population, with aortic stenosis and calcific mitral valve disease, managing the secondary hyperparathyroidism, the nephrologists really need to make sure that they're on top of that in order to slow progression of these issues. And then, as I said, most of the time in older people especially, it's TAVI versus SAVR. For functional mitral and tricuspid regurgitation, always optimize the volume status and blood pressure before you consider doing any sort of intervention. And then for endocarditis, again, something that's not directly under our control as cardiologists, but from an infectious standpoint, really encouraging patients to have an AV fistula created rather than using a catheter because the infectious risk is just so much lower. So I think, you know, my niche in the cardiology world is sort of a small, small group of us that do this kind of work, but I hope a growing group. And I think there is real value, particularly in centers where transplant volumes are high, to having a cardiologist like myself. So, you know, these patients have very complex pathophysiology and structural heart disease, and particularly as an echocardiographer, that's something that I can easily integrate the images into what I'm seeing with the patients. I really get a lot of enjoyment out of the interdisciplinary collaboration with my nephrology colleagues and the surgeons. And I think having sort of a consistent practice at the institution with just a small group of cardiologists seeing patients and you know, following certain protocols is helpful in many ways. It also helps patients build patients' confidence in their care. I sort of reassure them, you know, I have taken care of a lot of patients who are in your situation, and I will be able to see you through the kidney transplant and then also provide long-term follow-up for you. So a few take-home messages. Of course, I'm preaching to the choir here, but it's important to remember that all patients with advanced chronic kidney disease are at high risk for cardiovascular disease, particularly heart failure. In addition to using echo data in your physical exam to assess volume status, it's important to seek input from all members of the care team, including the dialysis unit and also the nephrologist and the patient, to understand how they're doing and then also optimize their medications. Anytime you have functional valve disease, particularly mitral and tricuspid regurgitation, always maximize the medical management before considering any sort of intervention. And then, of course, remain vigilant for endocarditis and rapidly progressive aortic stenosis. Thank you so much for your attention.
Thank you. Thank you, Dr. Bhave, for your excellent presentation. It's an excellent teaching point for us. And we will continue with question and answer now. Dr. Medina will help me to translate some question for you. Excellent conference. Thank you, doctor.
Carlos, ¿tienes alguna en el chat o quieres que yo haga una mientras vamos adelantando preguntas en el chat?
Ve haciendo unas y ya te pasas las del chat.
Vale. Okay, Nicole, thank you. Thank you so much for your outstanding presentation. And I think the interrelation of both conditions, you know, the kidney and the heart, it's way more common. I didn't know about the lack of use of peritoneal dialysis in the US compared to Colombia, but we have a bunch of them here. I'm not exactly sure about the percentage, but the first question I have for you is before the kidney transplant or in order to make patients eligible for kidney transplants, we use a lot stress echo, either stress or either exercise or the butamine. And I wonder what's your approach on that regard, and if after the 2021 guidelines for chest pain, the usage of SPECT has changed in this particular population, granted the vasodilation they already have, et cetera, et cetera.
Right. Yeah, those are excellent questions. So I think for me, the major limiting factor on stress echo in this population is image quality. So particularly with obese patients, if you can't get good resting images, then your stress images will not be as useful. And that is one major reason why we do use quite a bit of stress echo, but we often use nuclear. And at our institution, we have PET, which is really the preferred modality for obese patients. I do think the value of stress echo is that it's like one-stop shopping, meaning that you can get a picture of the valves, you get a picture of the right side, you can measure pressures, and you can look for ischemia. So if you've got good image quality and the patient can exercise, then exercise echo is always preferred. Dobutamine can be problematic. We use it, but it can be problematic in these patients, particularly if they have uncontrolled hypertension or if they've have any history of atrial fibrillation. The other thing that we encounter, and this I would say is actually more common in the cirrhotic population, the pre-liver transplant population, if their left ventricle is already hyperdynamic, then the sensitivity of stress echo for ischemia is lower. And you might actually have to stop the test if they become hypotensive because the cavity is obliterating. So those are a couple of the practical considerations there.
Gracias. Doctor Medina, hay una pregunta en el chat que dice, ¿cuál es el mejor momento para someter a un paciente de falla cardíaca avanzada con síndrome cardiorenal en diálisis peritoneal o recomendarla por parte del cardiólogo? Y si hay una utilidad de los diuréticos con bloqueo neurohumoral en los pacientes que tienen diuresis residual.
Okay, so Nicole, there's a question from one of our fellows, and the specific question is, on your experience, what's the best timing of starting renal replacement therapy, either hemodialysis or peritoneal dialysis in patients with advanced heart failure? And if you have any recommendation of using diuresis in those patients with neurohormonal blockade, in those patients that do not have, that are not making urine, that have zero urine output.
Right. So you're hitting on a very important question that I think is definitely a subject of debate in the heart failure world. So for patients who I see are usually patients who have longstanding kidney disease and then they develop heart failure. And to me, that point where they're developing heart failure that's refractory to diuretics, that's when I usually push on the nephrologist a little bit to start that conversation about dialysis. But it seems like you're also asking about patients who have advanced heart failure and are developing cardiorenal syndrome. Might there be a role for peritoneal dialysis? I wouldn't say that that's a very common practice, but it's definitely something that's a subject of discussion. And I don't think there's a clear-cut answer to that question. A related question that I think is definitely a subject of much debate is for patients who have advanced heart failure and kidney dysfunction, who should receive a heart kidney transplant and which kidney will get better with just a heart? And I don't think there's a clear-cut answer to that question either. As far as neurohormonal blockade in patients who don't urinate, so loop diuretics really, in my opinion, don't really have much value in patients who are anuric. I do think that aldosterone blockade can still be beneficial in these patients because, as I mentioned, aldosterone has these pro-fibrotic and pro-LVH effects, and it could also be beneficial in terms of blood pressure as well. And there is, like I said, there's some data from small trials suggesting that it may be helpful, but data from large trials are still it's still pending.
Sounds good. Thank you. Carlos, ¿tienes más preguntas? ¿Quieres que les haga de una del chat?
Sí, si quieres las del chat, ya te las doy. Entonces, hay otra importante que tal vez me parece muy relevante, es la utilidad del Doppler renal en los pacientes con congestión residual que tengan falla cardíaca y síndrome cardiorenal. Digamos que qué experiencia tienen ellos allá en el grupo que manejan estos pacientes.
Okay, so one more question, Nicole, maybe a couple more, is the utility of a renal vein Doppler in those patients with residual congestion, for those complaining of heart failure. Do you actually use it at all? Is it of any value?
I have not seen that used at all clinically. I mean, from a practical standpoint, usually we look at the IVC diameter to see if they're adequately diuresed as a proxy for right atrial pressure. I have not seen any data on renal vein Doppler in this population.
Okay, and one, I think this is a very tricky one, is what's the best timing for doing an echocardiogram to determining the real hemodynamic state, also for valves in those patients are either on hemodialysis or peritoneal dialysis? Do you do them right after they're finished with their session, one day after, kind of in between to assess how they do? What's kind of your experience in that regard?
Yeah, so I think it kind of depends on the situation. If you're trying to get an understanding of um, the variability of a lesion like mitral or tricuspid regurgitation, then you may actually want to do both to understand how much of it is functional. I mean, if you do TEs in patients with functional MR, I'm sure some of you have seen, you start the TE, their blood pressure is 100, and then, you know, a little while later it's 150, the mitral regurgitation changes markedly. So actually there's probably value in both, either right before a hemodialysis session or right after a hemodialysis session, both for mitral and tricuspid regurgitation. If the aim of your workup and treatment is to optimize someone for, say, a kidney transplant, then what I usually do is I look at whatever echo is available and try to understand, okay, what were the loading conditions when that echo was done? And then I usually talk to the nephrologist, make some medication adjustments, and give that person oftentimes a few weeks for that dry weight to be brought down and those blood pressures to be optimized. And then I repeat the echo. For something like aortic stenosis, it can be quite tricky. And as I was mentioning before, particularly in patients with an AV fistula, you can have a high flow state. And so if you look at the gradient alone, that will overestimate the severity of the AS. But one thing that you can use in that situation is the dimensionless index. So you can trace the left ventricular outflow tract velocity time integral and do a ratio of that to the aortic valve velocity time integral. And if that's less than 0.25, then that's consistent with severe AS. If it's greater than 0.5, it's suggestive of mild AS. But it's also important to keep in mind that just a good 2D image of the valve is really important too. That the whole, the AS assessment always should integrate all those components. There's no standard method or guidelines for occluding the fistula to see if the aortic valve hemodynamics change. With that said, some people will try that, use a blood pressure cuff to compress the fistula to reduce the output. One caveat is that if the patient has an AV graft, the graft, if it's compressed, can actually thrombose. So you want to make sure that it's a fistula rather than a graft before you try compressing it.
Okay, sounds good. Carlos, adelante.
Sí, hay una interesante ahí relacionada con la fístula arteriovenosa que nosotros nos vemos enfrentados en la evaluación prequirúrgica, y son pacientes que están con un gasto cardíaco aumentado y una hiperdinamia y que tienen hipertensión pulmonar, digamos, severa. ¿Qué tan frecuente es que ella encuentre esto y qué tanto manda a recomendar, digamos, el test de evaluación de la fístula, y qué tanto tiene uno que cerrar una fístula para el control de una hipertensión pulmonar por hiperdinamia?
So how often have you noticed that you have to shut down a fistula if you think you're having a hypervolemic or hyperdynamic state resulting in pulmonary hypertension?
That's a great question. So I have done it a couple of times, particularly, if the patient's hemodialysis dependent, and that, I think the fistula is their lifeline, right? So if they need to stay on hemodialysis, then sometimes our surgeons will downsize the fistula, make it a little bit smaller so the flow is less. That could potentially be an option. In the post-transplant setting, that is actually a time when I think that we should really be considering ligating fistulas for patients. And I actually took care of one young man, I still see him, but he first presented a few years ago. He had been completely fine from a cardiac standpoint before his transplant, and then afterwards developed high output heart failure with elevated neck veins and orthopnea and everything. And we did a right heart cath. He was in a high output state. They ligated the fistula, and it got better. And there's actually, there was a small trial done in Australia where they looked at patients post successful transplant, ligating versus not ligating the fistula, and MRI, the LV volumes were larger in patients who did not have the fistulas ligated, and the BNP was higher too. So I do think that particularly large fistulas with a lot of flow, in the long term, can place patients at higher risk of developing heart failure in the long run. But on the other hand, you need to make sure that their kidney function is stable before you take away that lifeline. So it's a really nuanced conversation that needs to involve the transplant nephrologist, the access surgeon, which in our case is our transplant surgeons, and then the cardiologist.
Excelente. Profe,
Sounds great.
allí, si ella tiene experiencia en pacientes, digamos, no en fase dialítica, pero sí en esa fase predialítica, del uso de antialdosterónicos, digamos, para proteger esa combinación corazón-riñón y el uso adicional de paratiromer y estos quelantes del potasio como para proteger el paciente de la hipercalemia y darle el beneficio de finerenone, por ejemplo, o espironolactona.
So Nicole asked question because it's already 2 p.m. We don't want to, go further. So what's your experience on MRA on the pre-dialytic state when you have chronic kidney disease and they're reaching the borderline of needing them? And if you kind of use any potassium, clearing up kind of medications to help you guide your therapy, they still need MRA, but they're at risk of hyperkalemia. And what's your management of that?
Yeah, so I'm very leery of doing that, particularly in that dialysis setting. And the reality is, it can be very difficult to predict when patients will progress from stage 4 or 5 CKD to needing dialysis. I actually just had a patient not long ago who's on dialysis already and is on lisinopril, wasn't even on spironolactone, but was on lisinopril and showed up in the emergency room with a junctional rhythm and a potassium of 6.2. And he was actually going to all his dialysis sessions. So I have a very healthy respect for hyperkalemia. And I generally tend to, again, it's a team-based approach with the nephrologist. I mean, hopefully someone with stage 4 or 5 CKD will be following very closely with their nephrologist. If I'm ever going to make any moves with diuretics or spironolactone, I always make sure that we collaborate and that the patient understands that we need to be very careful about that. Also educating the patient about minimizing high potassium foods. But honestly, once you're at that point where they're having heart failure symptoms and their blood pressure is high and their potassium is kind of marginal, then that they really need to, start thinking about going on dialysis. And I think it's helpful for patients to hear that from more than one type of doctor. Not only the kidney doctor, but also the heart doctor thinks this would be good for my heart. So making sure that, you have that collaborative approach is important.
Absolutely. Absolutely.
Thank you. Creo que ya estamos a tiempo. It's on times. Thanks, Dr. Bhave, for stay with us, an excellent teaching point for us. Muchas gracias a todos por acompañarnos. Gracias a todos los participantes por su asistencia y hasta una nueva oportunidad. Doctor Medina, por favor.
Thank you. Thank you so much,
Muchas
Nicole,
gracias.
for your outstanding conference. We really enjoyed having you, and we learned a lot, and hopefully it's going to help us take better care of our patients, cardionephrology patients here. And it really was great to see you again and to learn from you, and hopefully we can have you in Colombia in the future.
Wonderful. Thank you so much.
Bye-bye. Have a good afternoon. Take care. Bye-bye.
You too.